forgot to record one of the sessions. So I welcome everybody. Today is our first showstopper guest speaker talk. And it gives me great pleasure to introduce Dr. Abhijit Bhattacharya, who's one of my colleagues who I have worked with in Southampton. And in essence, I think the beauty of being able to learn from Abhijit is me, Abhijit, and Rajat were three colleagues who actually trained in lung ultrasound together and also did and trained in echocardiography together whilst we were in Southampton. Abhijit ended up going to Glasgow and is currently working over there and is, besides doing a fellowship in kind of neonatal hemodynamics, he works as a consultant in Glasgow at the moment. He has a special interest in neonatal hemodynamics and point of care ultrasound, and he's kind of been teaching with us for the last 3 years. Uh, he is an incredibly divine gentleman. And the best bit about him is I just love this teaching session. So, what you'll find is he's got a very unique style of teaching, very different to all the other speakers you're going to find in this course. Uh, I'm sure you'll enjoy this session. Before we start, I was going to say that once the session is over, we'll have time for some peer review. So by all means, do stay on, those of you who want to do peer review after the session is done. And we'll have basically the session will last approximately, I think, an hour, and there'll be time for questions as well. So I will let Abhijit take the floor. Thank you, Abhijit. God bless you.
Thank you, Alok. Yeah, that's no pressure on me now. Right, so Alok has done the introduction. Hello, everyone. Good evening. And we're going to talk about the abnormal lung today. So as Alok mentioned, I have a slightly different way of going through the presentation here. So I hope you like it, and I'll try to make it as engaging and fun for next 60 minutes while doing the abnormal lung. Right, so without any further ado, we'll just crack on. Electromagnetic spectrum. So we all are from the science background, and this is from your college days. I'm sure all of you know about the electromagnetic spectrum. And I tell you why I'm talking about this on the lung ultrasound session. So electromagnetic spectrum is it's a very wide spectrum, starting all from the gamma rays, which are the radioactive sources, and then going all the way up to the radio waves. The gamma rays are for the radioactive sources. We are using the X-rays for medical X-rays. The ultraviolet are used in the in sterilization techniques. You have the infrared, which is beyond our visible spectrum, which you're using for the thermal imaging there. Microwave are, excuse me. Microwave we are using as a microwave oven in our kitchens, and then you have a radio waves. Of the vast spectrum, what we can perceive, our day-to-day life, the visible spectrum is such a narrow band, starting from 380 nanometers all the way up to 780 nanometers. And you perceive all your life, the beauty of the universe and the cosmos in this narrow band of the visible spectrum. Had we not known about this electromagnetic spectrum, thanks to William Herschel, one of the astrophysicists from the 18th century, we wouldn't have made all this progress, in terms of medical devices, radio waves, listening to radio, simple things like that. We wouldn't have known about all these things. So it's a quite a wide spectrum, but we can only see visible spectrum with our sense of vision. So we need technology, we need machines to explore the rest of the electromagnetic spectrum. So that's the electromagnetic spectrum. Likewise, the ultrasound also have a range, right? It also has got a spectrum. So anything less than 20 hertz is like infrasonic. Your acoustic range, what we can hear is the range is from 20 hertz to 20,000 kilohertz, and anything beyond that is your ultrasonic spectrum, which we can't hear. Some animals do, like the elephants and mammals, but we don't. And we are exploiting this ultrasonic waves in our ultrasound scanners used to do the cranial ultrasound, now lung ultrasounds, echoes, and whatnot. And we also have, beyond the 2 megahertz, mostly in the range of triple digit megahertz, we are using the ultrasound for lithotripsy as well. So the point is, we need devices, we need the technology to exploit these sound waves, which we can't perceive with our sense of hearing. So I like this quote by one of the astrophysicists called Neil deGrasse Tyson. And what does he say? We are the prisoners of our senses. Our eyes can only see a tiny sliver of electromagnetic spectrum, and our ears can only hear a narrow range of sound frequencies. The universe is teeming with the phenomena that we can't directly perceive. Right? So beautifully written there. And we do need technologies to exploit all that spectrum and to see, beyond our senses. So ultrasound is, again, it's like a stethoscope, but beyond your senses. Using the ultrasound to make that clinical diagnosis and tailoring treatment to these babies. Having said that, we are not pulling things out of the thin air. It's an era of evidence-based medicine. So this is the ESPNIC, International Evidence-Based Guideline on the point of care ultrasound for critically ill neonates and children that was issued in 2000. That came up in 2020, and happy to let you know we had a recent publication from ESPNIC this year, published in Chest Journal, and Alok is one of the co-authors there. So you are learning from the expert in the field. Um, um, it's an expert consensus on framework for standardizing lung ultrasound training for the neonatologist. And as I said, the Alok is one of the co-author. And they have come with the expert consensus on how to train and how to use lung ultrasound quantitatively in intensive care. So point I'm trying to make here is it's not out of the thin air. It's an evidence-based medicine, and to kind of, I don't have to, make you believe in this because you guys already are sold for the ultrasound, hence you are in the course, but just making a point here. Having said that, can anyone tell me, just feel free to jump in, what exactly is this? No, wild guess?
Mechanical ventilation?
No, Mara, it is not. So reason I'll tell you what it is. The reason I have put it here is, to show you how far we have come from, 3 decades ago. So this is one of the first ultrasound scanner. So you can see it's a huge drum there, and the subject is inserted in the drum of liquid. Liquid is the water there, and this is one of the first ultrasound scanners. And I will do a bit of a chest thumping here. So the pioneer in use of the ultrasound in the medicine is by the Royal Infirmary Hospital in Glasgow. It was done by Sir Ian Donald. So that's from Glasgow, where I am right now. So that was a huge machine there, taking up a huge amount of space. It's cumbersome. You have to insert the subject in water because ultrasound loves water. It hates air. And from there, we have come a long, long way. Look at that. It's a V-scan or AirScan by GE. It's a handheld device, like your smartphone. And you can use this to scan and you can see the images on your smart devices. So from there to here, it's a long way we have come. And currently we are doing a pilot study on use of the V-scan on our transport with our transport team in transporting babies. So long way we have come. Now let's get to the meat of the presentation today. So for not only for the abnormal lung, for when you're doing the lung ultrasound, it has to be a systematic approach. The algorithm is this. I cannot stress enough, but the first thing is the clinical background, right? The lung ultrasound, you don't see the lung. 99% of the diseases of the lung, you do not see the lung, right? You only see the patterns. And I'm sure Alok must have gone through the different patterns of lung ultrasound. So because you don't see the lung and it's only the interpretation identifying the patterns, the clinical background is the key. So you need the clinical background, and marry that with the pattern you are seeing on your scanner, and then you come to the conclusion and the diagnosis. So clinical background, that's the number one thing. So sorry about that. Um, once you have the clinical background, the next thing you have to make sure is the presence of the bat wing sign, right? And I'm assuming here you guys have been through the normal lung ultrasound signs. So the presence of bat wing sign, we have to make sure that we can see the bat wing sign, and I tell you why. Because bat wing sign is the sign which is telling you your ultrasound scanner or the probe is on the chest, right? And I'll show you some of the scan images where if you don't see the bat wing sign, if you're not looking for it, you will misinterpret things. So it is imperative that we do see the bat wing sign. Then we have to uh, define the pleural line. So character of the pleural line, we will go through all of that. Then is the pleura sliding? And again, this becomes one of the most important step here because the algorithm changes. If the pleura is sliding, then you have different diseases. If pleura is not sliding, then you have different set of diseases. And to identify the pleura is sliding, the surrogate marker for pleural sliding is the B lines, or there's something called as lung rockets or comets, and I'll talk about that in the further slides. And if you can't make out with those as well, the final thing on your arsenal is the M mode. You can kind of employ the M mode, and you can make sure if the pleura is sliding or not. Once you have done that, talk about the A lines, the B lines, and the C profile. So once you have all of this plus the clinical background, then you come to a conclusion and make your diagnosis, right? So this is the algorithm we have to follow. Doesn't matter what is the reason for doing the lung ultrasound. If you follow this algorithm, you do come up with the diagnosis. Right, moving on to the RDS and TTN. When we talk about the respiratory distress syndrome and transient tachypnea of newborn, most of the time, more often than not, it's always like, looking at the chest X-ray, you always say like, oh, it's looking more like RDS, or it's looking more like a TTN, or vice versa, more like a TTN and less like an RDS, until and unless it is barn door cases of an RDS. With the severe RDS, you say, oh, that's RDS. But if it is grade 1, grade 2, you always talk about maybe RDS or, maybe TTN. So lung ultrasound take away that maybe factor, right? It gives you, tells you it is A, either RDS, or B, it's TTN, right? There's no ambiguity there. So, and that itself makes this very important tool, right? You can pick it up early, you can give the treatment early, and where your surfactant is most potential, efficacious in first 2 hours of life. And you don't give surfactant in unnecessary cases like TTN. So it becomes a very important tool there. So there have been a couple of studies, that's been done. So this is from early 2020, the UltraSoft trial, looking at the efficacy of the lung ultrasound in terms of the identifying RDS and giving surfactant. And I'll not go through the details of the study. It is just to make my point here that it's evidence-based. There's something called as ESTER study, the echo-guided surfactant therapy, again, the use of the lung ultrasound, because there was a worry when it is still in its infancy. It's, lung ultrasound have become toddler now, but when it was in infancy, the people were worried that we are giving more surfactant to babies with the use of the ultrasound, but that was not the case. We are identifying RDS earlier than it's clinically manifested, or the clinical parameters we use to diagnose the RDS. So lung ultrasound was making earlier diagnosis. And it holds true in the resource limited setting as well, where you're using the lung ultrasound to make the diagnosis of the RDS and giving surfactant in timely manner. Right. So we are not using more surfactant, rather we are using surfactant at the right time. So this aspenic guideline came in 2020. I haven't put up the 2026 here because this is more clearer here, but the 2026 also talks about the same thing. So again, to make the point, it is not out of the thin air. We do have the evidence here where it's talking about the point of care ultrasound or the lung ultrasound do make the distinction between the RDS and transient tachypnea of newborn. Right. A couple of studies again, lung ultrasound scoring. When it comes to diagnosis of the RDS, there's something called a BRAT score done by the BRAT and colleagues. And so there have been many studies have been conducted where they have found lung ultrasound score do predicts the need of surfactant in extremely preterm neonates. The studies were started with less than 28 weekers, then extended to 34 weekers, and we are seeing the consistently, statistically significant results where lung ultrasound is making correct prediction using the BRAT score in terms of diagnosing the RDS. And you can see here, it's quite sensitive and it's quite specific in terms of the, you can see the lung ultrasound is 86% sensitive and 88% specific as compared to the chest X-ray here. And it is all statistically significant, right? And we will talk about, and we'll go through the images if you're finding it too evidence intensive at the moment. So this is another study from JAMA Pediatrics. Again, I have made my point here. Right. Now moving on, how we make the diagnosis of RDS and TTN. So there are lung profiles, and again, I'm sure Alok must have gone through it. Just to recap, there is something called as A profile, B profile, a combination of A and B's A, B, and the C profile. So A profile is mostly with the A lines. And what are the A lines? And it is important because we're going to talk about the scoring, how do we make the scoring, and how do we make the diagnosis of RDS or TTN, or the pneumothoracis and the meconium aspiration syndrome. So it's all the scans and the signs will start from now on. So A lines. A lines are, I like to call that as a, remember that as a air. So A for air and A for artifacts. So the air is giving these artifacts, which are called as A lines. These are horizontal, sharp, and discrete, as you can see here. So these are the horizontal ones. These are very sharp, right, and discrete lines. And they are repetitive and equidistant. So you can see these are the A lines, which are repetitive, and equidistance. What we mean by equidistance, so from the soft tissue, this is your probe here on the soft tissue, and from here to here. So this is the distance that will be, all throughout the your screen. So these are equidistant lines, which are repetitive, and these are the horizontal reverberation artifacts. I'm not going into what I mean by the horizontal reverberation artifacts, how these are created. I'm sure Alok will be covering all those, but just note that these are the horizontal reverberation artifacts. And they do originate from the pleural line, and they can be present in a normal lung. Of course, normal lung is filled with air, or it can also present in pneumothorax, because in pneumothorax, again, it is all air inside the chest cavity, right? So those are the A lines. So when do we lose A lines? So again, I like to think it like this. So you have air inside your lung, so air and artifacts. So if it is being replaced, you fill it with the water, right? So water is filling up with, replacing the air. So that is the time we start losing the A lines, right? So anything that is liquid inside the lung will give you the B lines. Think of it as a curly B lines on the chest X-ray, right? So anything like RDS, alveolar edema, TTN, everything will give you B lines. Like there's a fluid in the lung, or pulmonary hemorrhage. Again, blood is a liquid, so it will give you B lines. So anything that is replacing air in the lung will be replacing the A lines, right? And as I said, air is replaced by blood or exudates. Exudates in infection, in pneumonia, blood in hemorrhage. You'll start seeing more of B lines and less of the A lines, right? And also when you have a collapse or consolidation, again, think of it as the alveoli, they're filled with air. If it collapses, right? Collapsing means there's no air inside the alveoli. So now you don't see the A lines, right? You start seeing, I don't know, collapse, consolidation, the C lines, the C profile on your scan images. So that's how we lose the A lines. B lines. There's a cute little bee there, but the bees have nothing to do with the B lines. B lines are well defined, they are hyperechoic, and they are vertical lines arising from the pleural line, right? You can see here, so it starts arising from the pleural line. They are vertical, they're not horizontal, and again, they are created by the sideways reverberation when you do the ultrasound. So it's a vertical reverberation artifacts. It erases A lines. As I said, to create a B line, you need to have a fluid. So if you have a fluid in some particular area, you can be sure there is no air there, right? So once you start seeing the B lines, it starts erasing the A lines. And you can see in the image that's been displayed here, whenever the B lines comes in the picture, the A lines disappear, right? Um, and I will tell you the difference with the comet tail artifacts in in the next couple of slides. B line starts originate from the pleural line again, and it extends all the way to the bottom of the screen. You should be able to see the B line starting from here all the way to the bottom, right? And that will be one of the differentiating factor between the B lines and the comet tail artifacts or the rocket artifacts. Um, Comet tail artifacts, if B lines terminates midway, we call those as the comet tail artifacts. And how do I remember it? Consider it as the curly B lines of the chest X of the lung ultrasound, right? Okay. Is it normal to have B lines then? Yes, of course. You can have some degree of fluid in the lung. Surfactant is a fluid. So normal to have B lines if it is less than 3 in one segment. When I talk of one segment, it is the space between the two ribs, so one intercostal space. So in this particular segment, if you can see less than 3 B lines, then that's normal, right? Anything more than that, more than 5 B lines or it starts coalescing or compact B lines, those are all abnormal. And when you see the coalesced compact B lines, that kinds of corroborates with the white out picture in the chest X-ray. That's what we if you do a chest X-ray on those babies, you will see a white out lung in the chest X-ray when you have a compact B lines on the lung ultrasound. Right. So yes, it is normal to have a B lines if it is less than 3 number in one segment, and anything more than that, that would be abnormal. Basically, it means that you are starting to replace the air with the fluid, more fluid. So that is something more than surfactant. It's not a surfactant. What is the difference between the comet tail artifacts, which is also called as lung rockets, and the B lines? Again, I'll play the videos here side by side so that, oops, right? And you can see the comet tails are lesser echogenic and than the pleural line, right? And they are ill-defined. They are not extending all the way to the bottom of the screen. They do not erase the A line, so A line is still present. They do not move with the lung sliding and they do not reach the bottom of the screen. Now, how the comet tail artifacts are created in the lung ultrasound, I'll not go into those details, but just to know that if you think something is a B line, but it's terminating midway and not reaching all the way to the end of the screen, you can be sure that that's a comet tail artifacts. Why am I talking of all this? Because comet tail artifacts or the lung rockets or the B lines, these are the surrogate marker for the pleural sliding. If you see these lines, you can be pretty sure, well, 100% sure that there is a pleural sliding. There is a pleura present and it's sliding, right? If you don't see comet tail artifacts or the lung rockets or the B lines, then you can't be sure that the pleural sliding is present. It might appear to you it looks like a sliding, but that could be because of another lung which is doing a traction movement, or it could just be a beating heart, which is give you that kind of false image of, which looks like a pleural sliding, right? So that's where it becomes important. So if you see comet tail or the lung rockets or the B lines, these are the surrogate marker for pleural sliding, right? Moving on. Now, if you don't see B lines or the lung rockets, how can you make sure that whatever you're seeing in front of the screen has got a pleural sliding or not? Because if you don't have a pleural sliding, as I said, the algorithm branches off. You can have a different set of diseases without the pleural sliding, you have a different set of diseases with the pleural sliding. So you have to make sure. So if you can't see any of those, you have to employ M mode, which is the motion mode of the ultrasound, and this is one-dimensional ultrasound view of the lung. Right, I'll not go into much of the detail here. Basically, with the M mode, you get two signs. If it is only air and there is no pleural sliding, right, which is a case of a pneumothorax, or it could be a big emphysema or a bleb, you can see something called as a barcode sign or a stratosphere sign, right? And it's called barcode or the stratosphere because you will see, the lines like this, which, if you draw, it looks like a barcode, right? And if it is a normal lung, which will be an air fluid interface, the fluid being the surfactant, or it could be any other fluid, which is basically telling you that there is no pneumothorax, you should be able to see something called as a seashore or a sandy beach sign. That's a sign of a normal pleural sliding. I wouldn't call that's my mistake. I wouldn't call that as a normal lung. I will call that as a normal pleural sliding, right? If it is a pleural sliding present, you will see a seashore or a sandy beach sign. And we'll see a lot of examples of that as we go along. And in pleural effusion, you see something called as a sinusoidal sign. Again, I'm not discussing that here today, but just to be aware, and the M mode, if there's a pleural effusion, there's something called as a sinusoidal sign, and that will be covered when you have the session on the pneumonia. Okay. Coming to the Brad scores. Now we have seen the A lines, we have seen the B lines, and we see how the B lines presence of B lines could be normal, or more of the B lines could be abnormal. Now we will, looking at all those, we'll try to score it, right, which was given to us by Brad's and colleague. And this is the scoring we use to determine if the baby has got a need for surfactant, which is respiratory distress syndrome. So there are three lung zones when the babies are born brand new in the neonatal unit. So we like to do the three lung zones. This is less than 48 hours. So immediately after the birth, once the baby's been delivered, got to the unit, huffing and buffing, then you let the nurses do their things, and then within or after an hour, when the baby has been settled, you do the scan for the if it is a case of a RDS or a TTN. So three lung zones you scan: upper anterior, lower anterior, and lateral. You have a maximum score of 18, which basically means a score of 0 to 3 in each zone. So bilaterally, so that is 6 3 is 18. If your score is 0 to 6, it's a mild disease. So it tends to go more towards TTN, right? Not more, it is TTN. Then you do not give surfactant if your scoring is 0 to 6. Moderate disease, 7 to 12. Now you are in the territory of surfactant. So if you're scoring 7 and above, depending on which recommendation you're following or which latest paper you're reading, the number could be 7 or 8. Not much of a difference, according to me. But if you're in that territory, you give surfactant, and more than 12, and unequivocally, it's a severe lung disease. This is a picture representation of that. So the upper anterior, the lower anterior, and the lateral, there's three zones. This is how the Brads et al. Have scored. So you can see if you're not seeing any B lines or less than 3 B lines, right? You are seeing the A waves or A lines here, right? You're allowed to have less than 3 B lines in one segment. We can't see any here. So that's a score of 0, right? You start seeing some B lines, right? You start seeing some B lines, and you get a score of 1. Your B line starts getting compact, right? You cannot count the B lines here, but you see there is no A lines here. There is no A lines. You can only see white out, right? So which is basically means the B lines has coalesced, it has become compact. So that's a score of 2. And then when you start seeing these puncted things, which are we call as a subpulmonic consolidations, you give that score of 3. So this is the scoring system Brett et al. Came up with. And we'll see some examples as we discuss the cases. And you'll have the opportunity to score it and to make a diagnosis here in the session. And this is the latest recommendation, which has come up with the SPNIC 2026, and focusing because it's RDS-TT, and I'm just focusing on the first 24 to 48 hours. You can see the recommendation has stayed the same. We are doing the upper anterior, lower anterior, and lateral. Now, I'm sure some of you must be thinking, what if the baby is being kept prone? Doesn't matter. Just make it instead of anterior, that will be called as a posterior one. You can still do the lung ultrasound. You don't have to change the position of the baby to do the lung ultrasound. Supine or prone, you can do the lung ultrasound. It will give you the same result. And I'm not going into this territory because this is outside the purview of this lecture here, but I'm sure Alok will be discussing this in the future sessions. And the slight change here, we can see only the 5 zones instead of 6, but that's not for discussion today. Right. And this is again retreating. This is from the SPNIC 2026, how they are scoring 0, 1, 2, and 3, which is pretty much similar as we have seen just now with the Brett et al. Scoring system. All right. Let's move on to the cases now, and we will go through the scans. Case number, and guys, please feel free to jump in with your answers here. So first case, it's a 32 plus 5 weeker, not antenatally optimized, just one antenatal steroid has been given to the mom, born by GS section in view of the poor CTG trace. Pretty in good conditions, abgas of 8 and 9, but as the story goes, soon developed respiratory distress in the form of grunting and recessions, right? Pretty much standard for a 32 weeker. So baby was put on a CPAP of 8 centimeter and 29% of oxygen. It's not touched 30%, isn't it? Usually, we start to go health skelter if it is 30% and more. Oh, that's an RDS. But this baby is 29% of oxygen. And the SATs are being reasonable, more than 90%. Right? So I'm sure you must be thinking in your head, could it be a case of TTN, RDS? SATs are 29%, must be TTN. And this is the lung ultrasound. You put the probe on, and this is what you're seeing in the lung ultrasound. Right? Anybody you'd like to jump in here? What we are seeing?
Yes, sir. This is Dr. Varun here.
Yeah, Varun, go for it.
Yes, sir. So as you advise that we should first look at the batwing sign which is present here. I can see the rib shadows and the pleura lining. So
Yep.
almost three ribs I'm able to see and 3 intercostal spaces.
Yeah.
And I can see the pleura sliding, but obviously the B line is also present. So that is a surrogate marker for the pleura sliding. And then this B line appears to be quite compact.
Mm-hmm.
And I do not see area of like pleural consolidation or a pleural breakdown in this scan.
Yeah, with an eye of faith. So you're absolutely right, Varun. That's a bullseye. You have described it brilliantly. So we can see a bat wing sign. You can see the ribs. You can see the rib shadow as I've highlighted with the 2 white lines here. The red ones are the ribs. Character of the character of the pleural line. It is not sharp. It's nowhere sharp. It's not discrete either. It has kind of a smudge effect to it. You cannot make out where is the line and where it has started blending in with the B lines. So it has a smudged effect. It's like, you have,
Right. Yeah, now I can see there is the like breakdown below the pleura.
Yes, exactly. So now you can, if you look more closely here, you can see that, sorry about that. You can see, Is it playing? Yeah. You can see there are these are the dots here, which are the subpulmonic consolidations.
Right.
It's a breakdown of the pleura. Otherwise, you should be able to see something like this. A very sharp and discrete pleural line, which is not the case here, right? You're seeing a smudged effect, right? You're seeing something like this, and subpulmonic consolidations. So what do you think? Just showing. This is not the right thing to show you just one image and ask for the conclusion here. But say suppose you are seeing this in all the lung zones. What are you thinking?
Yeah, so if you are scoring from the bad score point of view, this will be like 3 for this zone.
Absolutely.
So if we give the scoring in all the 3 areas, it would be like 9 score. Like, how is the bad score? Is like we double the score with the right and left, or it's only for the single lung?
No, we have to do both the lungs, but I'm just because I don't have other images here. I'm just showing you one image. So if you
Yes, yes.
you're seeing this picture in all of the lung zones, then yes, we give it as a high score. You can argue if it is a score of 2 or 3, but irrespective of that, the score is going to be in a severe category, and this baby is having RDS, right? Yeah. So although the baby is only on 29% of oxygen, that was delivered from my end, but you're picking up pretty much early. Baby will end up getting on to 40-50% of oxygen if you are not giving surfactant into this little one. Right. I can see a hands up by Ojas Pooja.
Yeah, hi, my name is Dr. Pooja. So, yeah, I was discussing regarding it being labeling as three. Looks like there is some areas of sparing, so we can label it as maybe category score of two. And I remember something like TTN will have some areas of sparing, or it is the rib shadow. That's why it's not showing. For type three, it usually will be complete whiteout.
Yes.
So
Yes.
that was my confusion.
Yeah. So that's why I said, that the argument will be about 2 and 3. And why not I'm going there? Because this is just the one zone I'm showing you, rather than 6 zones. We'll come to the pictures where we have all of it. But this is just a precursor. Lovely. Moving on. Again, I have put it up here to tell you to kind of compare it. So you're right, Pooja and Varun as well. So if you just look at this one, it scores as 2, right? If you see in all lung zones, that will be 12, severe category, needs surfactant. Moving on, same case, 32 plus 5 weaker. Everything is same here. The baby is on 31% of oxygen. This is another baby, right? Case number 2, 31% of oxygen. Now you are thinking, RDS, isn't it? Baby has crossed that holy grail, that at the marker of 30%. And you do a lung ultrasound, and this is what you see. What do you think? Anyone?
Hi, can I?
Yeah, go for it, Pooja.
Yeah, so in this, again, apart from seeing the battering sign and the lung sliding, I can see the A lines also and some B lines. So double lung point, so where we can see the B profile and A profile both usually, again, a feature of TTN is what I remember.
Yeah, lovely. That's correct, Pooja. And for the wider audience here, just explaining it. So yeah, you're bang on, Pooja. That's right. So you can see here the battering sign, right? If I mark it, so those are the ribs, and you can see the rib shadows here, right? And then this is a 2 lung view here. You can see there's a sharp and discrete pleural line, right, which is A line now. In this picture, where you see very minimal B lines, whereas on the other half of the picture, you can see a smudged effect. See that it's not is not as discrete. These lines are not as discrete as over here, and then you can see a sliver of A line, but it's mostly getting erased. See that? It's getting erased for the rest of it because the B lines are coming in the picture. So we're getting a 2 picture, like A profile and a B profile in a same zone. So that's the double lung point, right? DPL, and you see this. It's not pathognomic, but you see this on in TT, and you can see in other other conditions as well. But when you are trying to discern between the RDS and a TTN and a brand new baby, this will tell you this is a case of a TTN. right? Brilliant. You guys are expert already. Brilliant. Moving on. So let's not spend too much time here. What do you think of this one? Right. In the interest of time, I'll just go through this one.
Ignoring this one.
Oh,
Blura
yeah,
is
Wafa.
not. I'm Dr. Wafa.
Mhm.
Blura is not sliding, and I can see mirroring. So this pneumothorax.
Yeah, that's what the intention of getting this answer with this picture. So you're right about the pleural sliding, but it's not the pneumothorax, unfortunately. Oh well, fortunately for the baby. You can see pleural sliding. You can see a degree of mirroring here, and you can see mirroring if it is a highly reflective pleura. So the point here is we'll come to the mirroring in the later on images, but what is telling me here this is not a case of a pneumothorax. So basically you can see a B lines, you can see some cometal artifacts. If you see those, there's a pleural sliding, right? So pleural sliding basically means your parietal pleura, your visceral pleura is sliding. If you have both the parietal and visceral pleura, there is no air in between. Air in between is pneumothorax. If both of you can see the pleural sliding, if both of pleura are there, it's basically telling you there's no pneumothorax there. Right? So this is not pneumothorax. This is from the same baby. Okay. Again, if I have to ask you for the scoring, how much you going to score for this V1?
1.
1. Brilliant. Okay. Okay, I'll skip this one just now and we'll come to it with the case. Case number 3, 32 plus 5 weaker, again, incomplete optimization, GS section. All of the story is same. The CPAP of 29%, SATs are more than 90%, right? And this is a real case. I'm not making this up. Okay, similar story. And we have done the chest X-ray. This is what you are seeing on the chest X-ray. Sorry about that. I'm just closing that out. Yeah. So that's a chest X-ray there. Looking at that, you can make up your mind what you are seeing. CPAP of 21%, and what the radiographer has, the radiologist have given their diagnosis as the non-specific features that may reflect TTN, right? Again, I agree. This is what the chest X-ray looked like. Non-specific features. The cardiac silhouette is kind of not very discrete, but not disappeared as well. So if at all, if I have to argue about the RDS, it will be maybe approaching grade 1 as far as chest X-ray is concerned, but it looks more like a TTN, right? The volume looks kind of okay. So that's what the chest X-ray tells you. But you do a lung ultrasound on this baby, okay? And this is what you see. So R1 is right upper anterior, R2 is right lower anterior, R3 is right lateral, and so forth for L1, L2, and L3. Okay, so again, if anybody want to jump in.
Hi, I'm Shailesh.
Yeah, Shailesh, go for it.
Hi, so R1, R2 looks like predominantly A profile. We can see three lines in R2 and R1 as well. So a AB profile. R3 is, we can see the B lines are more prominent, predominantly B profile. L1 means all the images we can see the waves, the pleura sliding. So there is no pneumothorax. L1 is predominantly B profile. We can see the compact B profile here. L2. So L2, I'm not sure. I can see part of the B profile. I think it's part of the liver and the heart is coming there. And L3 again predominantly is B profile. It's compact B lines.
Brilliant. That's what we are seeing here. And just looking at all this, 6 zones, right now, I think we all can agree we are seeing more of a B profile rather than A. Everyone agrees with that? So if I have to score this baby, just let's put the Brad's thing on. So we are not seeing any score 0 in any of the scan, are we? No. So if you have to give number scoring for this zones, I think we all will agree it is within a band of 1 to 2, right? And if you have 1 to 2 in all 6 zones, you are already in the territory of RDS, isn't it?
Yes.
Everyone agrees?
Yes.
Yeah. Brilliant. So this baby is having an RDS. You can see here, RDS is a homogeneous disease, right? You can't have an area of the lung where there is surfactant deficiency and the other area of the lung where there is no surfactant deficiency, right? It can't be the case. It's a homogeneous disease. You have the global surfactant deficiency in both the lungs. And what that will do is it will give you a kind of a more of a B line, right? And less of the A line. So you'll see more of a B profile tending towards, the compact, more than 5 B lines to compact B lines. That's what you start seeing. And and this is exactly what you're seeing in this particular case here, in the right side 1 2 3 and the left side 1 2 3. More towards the caudal end, you see slightly more better aeration, which is like the apex of the lung, and more you go towards the caudal and the posterior side, you see more loaded lung there, right? But in if you score it, it is definitely coming more than 7. Yes, Ruby.
Yeah, so my question is like, would it matter like how many hours after the baby is born we did this scan? Because this could be just a transition, like, so if it is after 2 hours compared to after 6 hours, would it matter?
So yeah, Ruby. So the usual recommendation is you should be doing the ultrasound in the first, in first hour, like in 1 hour. You're right. They will be transitioning. That's why we are not doing it in the labor ward to see if it is the RDS or TTN. They do need time to, squeeze out their fluid from the lung. They are doing the transition. So in the first hour, so you've got the baby into the unit. Let the nurses do their thing. Baby is settled. Now you go in with your scanner for 1 hour and do the scan, and that's the time where you're gonna score the baby. And
So
it makes sense because
would you diagnose
sorry.
this as RDS?
Yes, we will diagnose this as an RDS, and it'll make you more clear when you see the next case, right? Right. So yeah, so the first in the 1 hour of life, you do the scan, and you want to do that because the recommendation for the surfactant, or the most efficacious, or the most to exploit the potency of the surfactant, that should be going inside the lung in the first 2 hours of life, isn't it? So you don't want to miss out the chance of that. You can give surfactant after 2 hours as well, but it will not be as effective as in the first 2 hours of life. Right, moving on. So we have given the surfactant on this baby. Ruby, just see the next images here, and this is just out of the interest and to show you how surfactant works and how it looks on the lung ultrasound. I want to make it clear we don't have any scoring system that has been validated to see the efficacy of the surfactant in these babies. Right, this is just out of the interest and to show you how the aeration improve. Same baby after the surfactant. Now look at the scan. R1, R2, R3, L1, L2, and L3. Now, what do you think, Ruby? Does it look better? It's
Much better. They look like 1 1 1 most of the places. Maybe L3, L2, maybe like 1. I don't know, but everything looks 0.
Exactly. So that's the beauty of it. So you can see now. You can ask me how much time later we should be doing it. When I have done this at 20 minutes after surfactant. There is a time required once you're given the surfactant non-invasive method and settling the baby again. Anyways, we don't have, if it's not been validated, it's not something you'll be doing and saying that, oh, this the score is this much. We don't score it because there's no validation there. It's not been validated by any study at this point of time. But to make my point, look, when you compare this to the previous one is definitely RDS. You're given a surfactant. Now look how beautifully the score, if you want to score it, how beautifully it has come down, right? It's more aerated. You can see more of A lines, less of a B line, which is coming as, within the normal spectrum of 0 to 3. And that's how it looks, right? Everyone agrees? I can't see any nodding head, but I will take that as a yes. And moving on. Right. Case number 4. Sorry about that. So this is MCDA twin 1, 34-week curve, 1 dose of steroid, incomplete optimization, born in good condition. Same story. CPAP of 8 is on significant amount of oxygen now, 40%. And this is the lung ultrasound. And I'll play that for you. Bear in mind, this is a MCDA twin 1. And very quickly, what does it look like? Oops. Sorry.
TTN. TTN.
Yeah. Even if you don't score,
and A-line.
yeah, you guys are expert already. Trust me. I mean, even without scoring, nobody has told me this is a score of this much. You have just looked at it and said, "Oh, looks like TTN," and that becomes very intuitive. The more you look, I can see more of an A line, less of a B line. I can't see any compact B lines. Maybe a sliver of it on the the lower posterior zone. LP3, maybe it is making some compaction there, but apart from that, the rest of the lungs looks well aerated. It has to be TTN, isn't it? Everyone agrees that's the case, right? The twin 2, right?
Just
So
query about the labeling, sir. We are labeling as RP1, RP2, RP3. What does it mean?
sorry, I didn't get the question, Shailesh.
The labeling as right posterior.
Oh, right. Yes, the baby was in prone position.
Okay, so RP3 is the lateral one.
Yes, so right posterior 3 is the lateral one. That's correct.
Thank you.
And so is the LP3. Yeah. Right. Okay. Moving on to the next case. So that was twin 1, and this is twin 2. Again, similar settings: 8 centimeter, 40%, huffing and puffing, and that's the lung ultrasound. What do you think of this one now?
What are the S?
Sorry, somebody said something.
So in RPN, we have A lines mostly.
Mm-hmm.
In RP2 and RP3, we have some coalescent B lines.
Yeah.
And then on the left side, LP1 and LP2, we have all of them. We have mix of A lines and B lines.
Yeah.
Mostly A lines.
Mostly A lines. Yeah, that's what I wanted to hear. So you can see here is something called as a sparing effect. Can you see that? RP1 is clear, LP1 is clear, LP2 is clear, LP3 is clear. You can see some dense B lines on RP2 and RP3. Am I right? Everyone agrees? I'll take that as an agreement in the interest of time. So you can see if you look closely at the RP3, at the peak of inspiration, the A line starts appearing. Right? At the peak of inspiration, the A line starts appearing there. See those? At the peak of inspiration, the A line starts appearing. Anyway, even if you don't see that, the rest of the lung, the 4 zones, it's mostly A lines. So that's a sparing effect. And again, if you have surfactant deficiency, it has to be a homogeneous one. You should be seeing more of a B line in all zones rather than, on the 1 or 2 zones having it. I would tend to go, if you score it, it's going to score low. It will be less than 7. So that would be a case, you will not be giving surfactant here. It tends more towards the TTN. Right, moving on. Case 6, early term.
Just a query about scoring. Why don't we include the dependent parts in scoring?
Sorry?
Why we are scanning only the 3 zones, not all the 5 zones, while we are scoring?
Why we are scoring only the 3 zones?
Yeah, means are we missing, like in ideal situation, we should be scanning all the part of the lung, right?
You can. I'm not saying you can't, but when we are talking, the validated scoring system is BRAD score, and the BRAD score looks at the 3 zones, and that is sufficient. But yeah, if you want to, you can. And mind you, like when you're doing the scan in this, the small babies, when you put the probe on, right? You're not just look at the scan here. You are not looking at one segment here. See that how many ribs are covered, right? So practically, you are covering the whole lung. Even when you're saying that it's a 3 zone, you are covering all the lung here. See how many ribs you are covering in one, just at the RP2, RP1. There's an overlap there.
So for the
So
completeness of the scan, we don't have to finish the remaining zones. We can just rely on this and go ahead with the manual.
and first 24 to 48 hours, yes. Yes.
Thank you.
Cool. Now moving on. I might overshoot the time, guys. I'm so sorry about it. I just get to.
Abhijit, take your time. There's no hurry. Take your time. Just take.
Sorry, Alok.
Yeah.
I
No,
get
no, no. Don't
excited.
worry. It's okay. Please take your time, because what we can do is we can do a fewer cases with peer review. So you have enough time. Go till 8:30. No problems at all. Yeah.
Lovely. Thank you, Alok.
No worries.
Just bear with me, guys. I'm taking more time of yours. But yeah, moving on to the case 6. Early term 37 weeker green pathway. If green pathway basically in the UK means everything was hunky dory until this time, right? The mom was absolutely grand, no concerns until 37 weeks. Has come in labor and delivered the child. So born in good condition, with the good ABGAS scores, DCC, delayed cord clamping for 1 minute. I don't need all that information, but I'm giving you those. Soon developed signs of respiratory distress and started on CPAP of 8, 35% oxygen. Early term, 37 weeks, CPAP 8 centimeter, 35% oxygen. What do? Anyone? Great. I'm glad, Ruby, you didn't say we give surfactant. Brilliant. So we do lung ultrasound. That's what I wanted to hear. And this is what you have seen.
A-line. Is pleura moving?
Sorry, somebody said something. I can't see who is what.
Is there a sliding or no sliding?
Ruby, you're testing my knowledge. It's a question for you guys. What do you think?
All A-line here.
All A lines. Yeah, I agree. All A lines. Anything more?
The missing part of
No
the
lines.
Sorry, Prachi, your voice is breaking, so I couldn't make out anything.
I'm not sure I can see pleural sliding there.
Okay, Hafiz, you are not sure about the pleural sliding. What do you want to do?
M mode.
M mode.
Okay, everybody agrees with that?
The A lines are not equidistant,
Yes.
like we should see them.
Right.
And not
And
going
the truck,
Right. So
is there
that's
also a truck line?
Can't see any B lines. We should go for M mode, I think, to look for pneumothorax.
okay. Brilliant. You guys are expert. But caution here. You guys are jumping from top to bottom, left, right, and center. Where is you have to follow the algorithm. So clinical background you got, it's an early term baby, reasonable weight, and then is on CPAP of 8 centimeter, 40% oxygen. A lot of oxygen. Presence of bat wing sign, everybody agrees? We see bat wing sign. Are we on the chest? We are not on the abdomen?
Yes. Yes.
Excellent. So bat wing sign has been established. We are on the chest. Character of the pleural line, is it sharp, discrete?
Yes.
Yes.
It's regular. It's not broken. Excellent. Is pleura sliding? That's the question here. Can we see the B lines?
No.
Can we see any lung rockets or lung comets?
No.
Excellent. Those are the surrogate marker for B lines. Pleural sliding, right? So we don't see that. But just looking at it, it looks like a pleural sliding. Some of you might have been thinking like, it looks like a pleural sliding. Why we are saying it's not? And I'm not saying it's not, but I can't see any B lines or the lung rockets, and that raises question. A lines we can see, B lines we can't, and definitely there is no C profile here. So you do an M mode. That's what we see now. Right? So once you have done the M mode, you're interrogating. You're interrogating through the pleural line. Just be 100% sure when you're doing the M mode, you have to be at 90-degree angle, right? You have to be perpendicular to the pleural line. Irrespective of M mode, actually, when I say it is imperative to see the bat wing sign, is because if your probe is angulated in in relation to the pleura, you're not going to see the bat wing sign. Right? To elicit the bat wing sign, you have to be 90 degrees, like perpendicular to the pleural line. And same is true for the M mode as well. So you have done the M mode here, and what do we see? You see something called as a barcode sign, right, or a stratosphere sign, which is basically all lines like you see in the barcode. And when you started looking at the barcode sign or the sandy beach sign, when we started learning ultrasound, it all looks same to me. You can argue, this might look like a sandy beach sign. Why it is a barcode sign? I can see some granularity. So it looks similar. So it's a best practice whenever you are suspecting about, it looks like a barcode. Try to go over the part of the lung where you can see the B lines and scan that part as well, and then you can put it side by side, and you can be sure that that's a barcode, that's a sandy beach sign. And I'll show you the example of that. So this is an air leak, right? So this was a case of a pneumothorax, term baby, big one, pulling off a large intrathoracic pressure because he was not happy with the CPAP, and then he popped off his lung. So that was a case of an air leak. So lung ultrasound is superior to chest X-ray in diagnosing pneumothorax. There should not be any doubt about it. Chest X-ray is 75% sensitive and 100% specific, whereas your lung ultrasound is 98% sensitive and of course 100% specific. But it comes with some problems because it's 98% sensitive. It comes with problems of its own accuracy, because you're going to pick up a very tiny sliver of air as well. So in the cases like when you have chronic lung disease, or the small blebs in the bullets you have and the lung, with the CLDs, you're going to pick up those. And it looks like a pneumothorax, but it's not. There are signs to make out that difference. And most of the time I've been asked this question: can we quantify air leaks? Well, yes and no. If you see a smaller air leaks, you can't quantify. If it is a huge one where you can see a lung transition point, then you can, with pretty much surety, you can say that's a big lung, kind of a pneumothorax, depending on how many zones you're looking at, and you can see all air. But with the smaller ones, no, you can't quantify it. And again, this is a bit of an evidence here from the Cochrane, NEGM, and Espinic, of course. Pneumothorax is with pretty much 99 to 100% accuracy, you can make a diagnosis. And that is a statement from the Espinic in 2020 and similar in 2026. Okay. What is the advantages? I'll just quickly run through it. Immediate, repeatable, cost-effective, and reduced radiation exposure. I'm sure you all guys knows about this. Where you can have false positives, as I said, if you have a main stem intubation, like a single lung intubation, you can have false positives. If there's a blebs or bullets or emphysema, you can have false positive with the diagnosing pneumothorax. False negatives, because it is 100% specific, there is no chances of false negative, right? So inappropriate technique, I would say. Air fluid ratio curve. Whenever you are approaching a baby with a lung ultrasound, with a probe in your hand, I like you to think in this particular, remember this particular picture here. And all, you would be able to make a reasonable diagnosis when you are on, using this particular picture. So on your x-axis, you have got the your air, and on the y-axis you have got the fluid, right? As I said, the more fluid you have, the less of the A waves. A lines, sorry. And the more of the air, you will see only A lines. So pneumothorax is 100% air, you only see the A lines, right? Normal lung, some surfactant will be there, so you will see some B lines. Interstitial syndrome, as progressing, you start seeing more of the B lines, as you can see in the schema there. And then you can see here the pneumonia, atelectasis, and pleural effusion, like they just have 10 to 5% of air, and rest is all fluid. And lung ultrasound loves fluid, right? Not lung ultrasound, any ultrasound loves fluid. That's why you use the gel on the transducer, right? So it augments the ultrasound. So basically, in pneumonia and in pleural effusion, you start seeing the lung, right? Because there's no air, it's a fluid. And that's the only condition where you actually see the organ in the lung ultrasound. Rest of the cases, it's always about the patterns, recognition of the patterns. So the point I was trying to make here, more air on the A lines, start filling it with the fluid, you'll start seeing the B lines, and then if it is all in a fluid field, it will be pneumonia, pulmonary hemorrhage, pleural effusion, and all that. Not covering it today, just making a point there. So pneumothorax is a diagnosis of air within the air. So lung is a sac filled with the air, right? Parietal pleura, visceral pleura, sliding positive, right? And then air. So you see A lines, right? Throw in some water, you start seeing B lines. You don't have this visceral pleura gone. Boom, right? Because there's a pneumothorax and it's all filled with the air. B lines gone, no lung rockets, there's only parietal pleura, and that is giving you the A lines and only A lines, right? So you can make it out. Absence of pleural sliding, no parietal pleura, visceral pleura. A prime profile, we like to call that as the A prime profile, where it's a complete absence of B lines or the comet artifacts. And when you do the M mode, you will see the barcode or a stratosphere sign, and that is pathognomic of pneumothorax if you see that. And lung point, if you see the lung point, the transition zone, that is also pathognomic. Basically, the lung point is a transitional zone between a normal aerated lung, where you can start seeing the visceral pleura, and the point where there is no visceral pleura. If you encounter that, that's a pneumothorax. And again, this is the algorithm I like to use. Is pleura sliding? Yes, then it's no pneumothorax. Always, if pleura is sliding. How do you make sure pleura is sliding is with the B lines? If no pleural sliding, you want to look at the B lines, right? Can you see the B lines? If your answer is yes, again, no pneumothorax. If you don't see your B lines, then the answer is pneumothorax, right? No pleural sliding, no B lines, pneumothorax. And if you see your lung point, and then again, it's a pneumothorax. Okay, there is something called as a blue protocol, and I don't want to go through all this because it encompasses the pneumonia and the COPDs and pulmonary embolisms and all that. We don't need any of that. But just to make it a point that I'm not pulling things out of the thin air, there's something called as B prime and A prime profiles, and been described in the blue protocol. But I'm sure when the pneumonias will be covered, and they'll go through it. Pleural sliding. Okay, let's see examples now. Right, feel free to chip in here. What do we see?
I'd like to have a go.
Yeah.
Hi. So there is the battering sign is visible, and there is a casting of shadow underneath each rib, and we can see 1, 2, 3, 4 intercostal spaces.
Yeah.
There are multiple A lines, and there is good depth. Yeah, I don't think I can see any B lines and or comet tails over here. The sliding, it doesn't look to be significantly sliding. So I'd like to do an M mode.
Excellent, Hiba. Brilliant. That's a very accurate description of it. You're correct. So I haven't shown you the pleural M mode here, but yeah, you're correct. So you can't see the B lines there. What do you think about this one?
So this is now in the L3. Do you want me to go or somebody else?
Yeah, go for it.
Okay. So this one also shows 3 ribs and 2 intercostal spaces. This side, I can see there is good lung sliding. There are comet signs over here. It's showing mainly on this side of the screen. There are multiple A lines and good depth and penetration.
Yeah. What do you think?
This one looks more of an A profile lung. It looks like a normal side. L3 looks normal to me.
Pleural sliding, normal lung. Okay, brilliant. A prime profile. So what you have described, Hiba, is a A prime profile. So same picture here. So bat wing sign, yes. Pleural sliding, not sure. There is no B lines, no committal artifacts. And if you don't see any of the B lines or the committal artifacts, that's called as a A prime profile, right? And if you see that, please do M mode to be 100% sure that you are dealing with a pneumothorax. Right. How about this one? Someone?
Can I just check something, Avji, before we move on?
Yes, please, Hafiz.
The image which Hiba described, was there a zone where we could see B lines, and towards the top of the image, there was no B lines? If we could go back 2 slides back.
Yeah, I know what you mean. So in this particular one, yeah.
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 So towards the right of the screen, I can see some B lines plus A
You can
lines.
see B lines here, but you can't see B lines here, is what you're telling me, isn't it?
Yeah.
Yeah.
So,
And you're asking, the next question must be, is it the transition point, lung point?
that's the question I had when I saw it.
So you're right in asking the question. Answer is, I don't know. What do we do?
M mode.
Yes. So you have to do an M mode to find that out. It looks like, but it could be, you have B lines there and you don't have the B lines on the other segment. That's completely normal. It can be in a normal lung as well. You don't see B lines everywhere, right? So and the answer is, I don't know. You say this, you do the M mode, right? You run the M mode through this, and you'll be able to see if there is, run on both the segment, and you'll be able to see if there's a barcode sign or a sandy beach sign.
Yep.
Make sense?
Yep. Thank you.
Yep. Brilliant. Moving on, A prime, this has been discussed. Okay. Anybody would like to comment on this particular one? Right. In the interest of time, again, this is A prime profile. You can see the bat wing sign, right? You can see the pleural lines, and that's extending. You can see it's extending all the way to down. Look at that. It's all equidistant, as I said. These are all equidistant, but I can't see any B lines. I'm not sure about the pleural sliding here. To my eyes, it doesn't look like a pleural sliding, and that's been corroborated with the absence of the B lines or the lung rockets. And we have to do what? M mode. Right. How about this one?
Not sure about. I mean, I can see ribs, and
yes, we can see the ribs.
Quite sharp.
Mirror imaging.
Yeah.
There is mirror image of the ribs here, and there is A lines, but I'm not sure about lung sliding, so I would do M mode.
Brilliant. That's brilliant. What are you seeing here? That's moving, isn't it? Okay, let me remove my.
Is it the lung pulse from the heart?
Excellent. You guys are already expert. You don't need me. Yes, that's a lung pulse from the heart. So if I ask you, Leave, if I'm pronouncing your name right.
Yeah, that's fine.
Yes. When you do the M mode, how this lung pulse will look in the M mode? What do you call those things? Just asking.
I don't really know. I've never seen a lung pulse on M mode, but I suspect that might create some movement, so there might be some sandy beach artifacts instead of barcode.
Yeah. No, you will see barcode. The barcode will be there, but the barcode, there will be some vertical lines called as the T points. But you don't have to go for that. That's too geeky. It's not adding you any more new information, but just checking. You guys know everything. Brilliant. So that's a barcode sign. We have done the M mode on this particular image we have just described, and this is what we have seen, right? All lines. I'll not go into the detail of it because you guys know already. Lung point, again, I've said already, most specific sign for pneumothorax. And anybody would like to comment on this one? Anyone? No one?
Can you hear me?
Yes, Ellen, go for it.
Yeah, hi. So you can see batwing sign here. In terms of the pleura on the right side of my screen. I think that's probably the same for you. You can see clear. The pleura is more discrete. On the left side, you can see lots of B lines, which is consolidated at some points. On the right, where you can actually see the A lines, and you can't see any B lines or comet tails, and there the pleura. I'm not really sure if that's sliding. I can't see it very well, so this might represent lung point where there's a pneumothorax on the right side. With a consolidated, well, more RDS or
yeah, brilliant. So that's the lung point. That's the lung point. Yeah, brilliantly described, Ellen. Thank you. So that's exactly what it is. You can see on the cranial end, you can see the B lines, which is surrogate marker for pleural sliding. So you're pretty much sure there's a pleural sliding there, which is not the case on the caudal end. You cannot see any B lines and the lung rockets, and you have to do the M mode to find out. So that's what we have done here. And this M mode, as you can see, I'm not sure if you can make it out, but this is the M mode interrogation is being done on this part of the screen, right? And what we are seeing here, anybody?
Seashore.
Yes, seashore. That's correct. So that's your sky, right? And that's your sea, and that's your beach, sandy beach, right? So that's what we are seeing, sandy beach sign or seashore sign. That's normal part. That's the normal pleural sliding, right? You can see the nice granularity there. Brilliant. So that's on the normal part, and seashore sandy beach. Yeah, that's what we described. Pardon my crappy animation here. Right. Oh, that's what I wanted to show you. Why I call it is the radiologists have they stretch their imagination. I tell you guys. Until unless I was putting this picture side by side, I was thinking like, how does that look like a seashore? But it's pretty convincing with that picture there, isn't it? Everyone agrees? Sandy beach sign. Right. Okay. And then we did the now if you see the marker here, the M mode interrogation is in this part, right, where there was lack of B lines. And I have made the transition while doing this scan, while doing the M mode scanning. So the first part of the scan, I was over the part where I can see the B lines. You can see nice sandy beach here, right? Nice sandy beach. And then the midway, I transition or move this cursor to the area where the questionable absence of B lines, and you can see a stratosphere sign. And it's very different, and and you can make out the difference. Everyone agrees? So I employ this technique while I'm doing the lung point transitions. It helps me, to be 100% sure that I'm looking at the barcode sign, because when you look at side by side, it becomes very, very clear, right? And that's your sandy beach, and that's your barcode. Make sense? I'll take that as a yes. Okay. Okay. Well, it's coming up again. This was the baby when we were doing it. Well, the ultrasound was done on this particular baby. Okay. Mirror image, and we have seen this multiple times now. So having a mirror image or a truck sign, we used to think that if you see that, you can be pretty much sure that it is a case of pneumothorax. That's not the case. The pleura is very reflective, so you can see the mirror artifact. Need not be pleura only. There are other part of the in the abdominal viscera. You can see the mirror artifacts, and so is the case in the echoes as well. So, and you don't have air in the heart, right? Or you don't have the air in the viscera, the parenchymal organs in the abdomen, but you will still see the mirror image. So having mirror image, just seeing the mirror image is not It's not telling you with 100% surety that there is a pneumothorax. What you have to do, if you see a mirror image, it's indicating you something. It's a very reflective pleura there. Either, it's a very, what do you call, 10 to 12 megahertz of a probe you are using. You are directly bang on over the 90% degree of the 90 degree over the pleura, and you are getting this kind of an image. So it's telling you that. But when you say this, try to look out for the lung rockets or the B lines. If that's absent, you have to do an M mode. So if you see a mirror image, don't conclude that I've seen the mirror image and there's a pneumothorax. We used to think that way, but it is not the case, right? You have to do an M mode and figure out if we can see a barcode sign there. So again, it's called truck sign. As I said, the radiologists have very vivid imagination. So these are the wheels on the both side, or the ribs on the both side, very reflective pleura, and that's a mirror image of the ribs on the both side. Okay, you can't see any B lines here, so that is telling you it could be a case of pneumothorax, which was the case here. But I have shown you one more previously where there was B lines with the mirror image, and that was not the case of pneumothorax. I hope that made it clear. Anybody like to comment on this particular image here?
This liver.
Yes. Yes, Wafa, that's liver. Anything else you can see or you don't see? All right. In the interest of time, as I'm trying to make my point here. Now, this baby actually had pneumothorax, not a massive one, small one. But when we are doing this kind of a plap with the convex probe here, you can see, of course, the liver, and you can see liver on both sides. Look at that. Yeah, so liver is coming in the picture on the both side. So it's being reflective and showing the liver on the both sides. If you guys have experience with doing echoes, this is not how it should look when you are doing this particular scan. But yeah, trying to make my point, it can be reflective and can show you the mirror signs. If you have it, do doubt pneumothorax and do M mode, not in this particular case here, over the lung. It indicates you towards the reflective pneumothorax, but if it's not telling you with 100% surety, there will be a pneumothorax. All right. Blimey, I have given out the name already. I wanted to ask you guys if you recognize these guys. All right, so that's the Ian Donald. He was the pioneer for the use of the ultrasound here in Royal Infirmary in Glasgow. And the guy here is the Christian Doppler. There's a fun fact with these two guys. I haven't put this, just for the sake of it. Ian Donald, as I said, he started using it. Christian Doppler, so he's the astrophysicist, Austrian astrophysicist, and he came up with the Doppler effect, which we are using in, ultrasound. We are using that in astrophysics and Doppler shift in light. So that's by Christian Doppler. The fun fact is, fun fact for us, not for Christian Doppler, how he died, or Ian Donald died. The reason for their demise was pneumonia. They didn't have a lung ultrasound to diagnose that at that point. All right. Okay. Case number 7. Term baby, poor maternal CTG and spike in temperature, born with meconium stained liquor, and baby was limp. Apgars 6 and 7, required positive pressure ventilation, inflation breaths, followed by ventilation breaths, now grunting and is tachypneic. All right. Of course, we have done a chest X-ray. I will not quiz you with the chest X-ray. I have given you the sorry about that. Given you the reporting from the radiologist colleagues, and you can see appearances would be in keeping with infection, and I agree with them. Right? You guys agree? So that's what the chest X-ray looks like. Right? It's well expanded, kind of well aerated, right? 8 intercostal spaces. You're losing cardiac silhouette on your right, but you can see the perihilar opacities on your right. Right. Not discussing the chest X-ray, but that's the report there. And as we always do, we have done the lung ultrasound, and that's all 6 zones there. Anybody would like to come in and comment?
Mainly B-line.
Wafa, I will stick with the algorithm. So we got the clinical context. Can we see the bat wing sign everywhere? Yes, I'll take that as a yes. And then define the pleural line. Any would like to define it? I can't see all of your names. I don't want to put you on spot, but anybody volunteering to define the pleural line here?
On the left side, the pleural line is well delineated. On R1 and R2, we see like a small breakdown. And as for the A lines, we see them everywhere, but in some areas we have coalescent B lines with A lines that appear during inspiration.
Yeah. So what do you think? What's happening here?
So, yeah, we have some breakdown. I think there is some signs of consolidation on R1, R2 mainly.
Yeah. Cool. Thank you, Bernard. Am I saying that right? Yeah.
Yeah.
Thank you. So you're right. So again, all 6 zones. We got the clinical context, meconium stain, like radiologist report is query infection in keeping with infection. So we can see bat wing sign everywhere. So we are on the chest, and then pleural line. So you can see the pleural line. Focus here. You can see it's kind of a in R1 category. You can see the pleural line is breaking down. It's thickened, right? It's not sharp and discrete as compared to this particular one. Look at L3. It's so sharp and discrete. Just compare the pleural line on R1 and L3, right? So sharp and discrete pleural line looks like the one in L3. But look at the R1. It is thickened, it is irregular, broken, and so is the case with the R2. And you can see more of a B line there. Whenever the B line comes in, it's erasing the A line. Similar picture on the R3. Yeah, you can see the breakdown here on that particular segment. Yeah. And so is the case in L1. L2 shows some degree of a discrete pleural line. So what it's telling you is like, there's a patchy collapse consolidations. Yes, you will call that as a subpulmonic, subpneumonic consolidations and collapses. It's not massive. Those are small collapse consolidations, making the pleura irregular and thickened, right? So is the case here as well. As compared to the one which you see in the L3, it's nice and discrete and in a couple of little lines, B lines there. So it has a patchy appearance, over the 6 lung zones. Some are very well irritated, sharp and discrete pleural line, whereas in some zones you can see the pleural line has become thickened, it's broken, it shows subpulmonic consolidations or collapsal consolidations. So where do we see that kind of a situation? Now, the clinical background of this baby, it's a term, poor CTG delivered in emergency, meconium stain, like being a term, I tend not to think about the RDS, and RDS should not be having a patchy picture. The L3 is well aerated, whereas the R1, R2, L1 is, it's very patchy. So it should not be RDS. TTN doesn't look like, you should not be seeing collapse consolidation in TTN. So going back to your the clinical context here, the thing which is drawing our attention is meconium stain like. So this baby was distressed. It's a term baby. For some reason, it was distressed. So was the poor maternal CTG got delivered with the background of the meconium stain like. And now that's the picture we see. So is it safe to say this is a case of meconium aspiration? Well expanded lung, yes. The baby has, kind of inhaled air. It's opened up lung. It has ingested meconium as well. By the virtue of the anatomy, the right side being more acute in angle, kind of more obtuse in angle compared to the left side, the more of the meconium has ended up in the R1. That's where you end up if you aspirate anything, right? So you can see that kind of a picture in R1, R2. It goes more to the right side and not so much to the left side. And that is very clearly seen in this scan here, right? So this is a case of a meconium aspiration syndrome. Does that make clear? Any question, any comments, guys?
Very nice case. Thank you.
Yeah, everyone agrees? I'll take that as an agreement. So meconium aspiration syndrome, clinical context is the key. Not only for meconium aspiration, clinical context is the key for any condition, right? You have to, because you are seeing the same A lines and the same B lines and the same pleura, you're seeing the patterns, and you might even want to score that baby at that point of time. But 38, 40-week or term baby, we're not thinking of RDS as the first thing. I'm not saying that it can't happen, but that's not on the top of my list. And when you see the meconium and that kind of a picture, that's a meconium aspiration. So this baby will have tachypnea, will need extra oxygen. You don't have to think about the surfactant here. Give extra oxygen, vapothermos, CPAP. He will be huffing and puffing for some time. If his gases are fine, just continue on that. If not, he might end up getting intubated. This is another case, similar kind of a picture, background, and that's the lung ultrasound. Anybody would like to come in? No volunteer?
I will comment.
Yes, Bernard, go for it.
Yes, thank you. So we have a second flora in all most of all the segments.
Lung zones, yeah.
Yes, and we have a small breakdown, mostly on the right side.
Yep.
But also at L1, L2.
Yeah.
The clearest one is L3, but at L3 also we have some areas of breakdown that we see on inspiration. And
That's right.
comes and then it clears.
Yeah. Yeah, absolutely. Yeah. So we will always, go through, go the systematic approach, and yes, you are right what you have described, and you can see the lung picture is worst on the right side. Everybody agrees compared to the left, right? And aspiration, if it is a massive aspiration, don't get me wrong, it will be similar both the sides, but if it is a, kind of a subtle mild aspiration, it'll end up more on the right side, and that's what you see on the lung ultrasound as well, right? The chest X-ray might always come as query infection. It could be the case. It could be an infection. That's why baby was distressed, has passed meconium, ended up aspirating meconium. Could be the case. But when you see this kind of a picture, you can be pretty much sure that this can't be infection here in the lung ultrasound, right? Yeah. If this is the case of an infection, it's like miliary tuberculosis, or full-blown pneumonia bilaterally involving all the lung zones. This baby will be knocking at the heaven's door. So this is a case of meconium aspiration yet again, right? Everyone agrees? So clinical background is the key.
At what time you did the ultrasound?
On this particular cases?
Yes, the meconium
somewhere around, by the time we get the machine and put the probe on the baby's chest, invariably it goes beyond 40 minutes to 1 hour. Baby needs to come down from the theater to the neonatal unit, and then, weighed and put into the incubator and, put the respiratory support on and everything. We want to do all that. And then we call for the chest X-ray. We used to be the practice. Now we do lung ultrasound. And, by that time, we get the machine and scan it. So invariably 40 minutes to 1 hour, right? So meconium aspiration syndrome, clinical background, always, not only with the meconium, any disease, it's a non-homogeneous changes, right? It'll be discontinuous pleural line, patchy collapse consolidations in different lung zones. And most importantly, it will be interspersed with the normal A profile, which is telling you the lung is well aerated, but there's been breakdown because of the meconium, which kind of neutralizes the surfactant. I think we are at the end, and I'll leave that with you. A generation of physicians will need to be trained to view this technology as an extension of the senses. So, like your stethoscope, use this as a stethoscope. As the previous generations has viewed this stethoscope, you will be using the ultrasound probe for many more things in the future. With that, I conclude. The last one is this, and anybody would like to take an attempt on this one? It's a tricky one. Come on, guys. No take on it?
Looks like barcode, but it won't be. It's something else.
You already know I'm playing tricks here, isn't it? It looks like a barcode. So this is what I wanted actually. So if you are seeing A, B lines everywhere, right? By the end of the lecture, if you see barcodes on every damn image you see, you're right? You are seeing lung ultrasound. You're learning lung ultrasound. But unfortunately, this is not the barcode. This is the Cassini space probe sent by the NASA a decade ago now, and these are the rings of Saturn, right? So I'm glad that you are seeing barcodes everywhere. Right. That's the end of the lecture. I'm happy to take questions.
One query regarding the timing of the BRAT score. Why the
Shailesh, your voice is breaking up, Shailesh. Can you come again?
Yeah, is it better now?
Yeah.
About the timing of the BRAT score.
Yeah.
In most T10 babies, they would start getting better after 2 to 4 hours. So will it be better to do the scan after 2 to 4 hours?
No. So I would do that at the first hour, 1 to 2 hours. Because, as I said, the lungs can, it kind of precedes the clinical changes and the X-ray changes. All right. So, the lung ultrasound scoring is kind of the paper called it as a predictable. I don't want to use the predicts. We sound like a crystal ball reader. Basically, it precedes the clinical changes, the need of the FiO2. You can get up. You might be at the 1 hour of life, the baby is at 25% oxygen or 27% oxygen, and you might be thinking, oh, it's all right. It will come down. Baby will get better. And then you wait for the chest X-ray for next 2 hours or so, but then slowly it's creeping up. But if you do the lung ultrasound at that point, 25 or 27%, it's going to tell you, is it a case of RDS? It's going to get worse, or is it a case of TTN, right? So it precedes the changes, clinical changes, or the increase in FiO2. So you will do it at 1 to 2 hours of life. Plus the fact that you want to give surfactant, within the 2 hours where it's most efficacious. I hope that answers the question, Shailesh.
Yeah, thank you.
Right. There's a QR code here. If you guys just can scan that and send me a feedback, and in a sense, if you like what we have discussed today, any changes you want me to do for the next session, approach to the teaching and all that, if you can just give me the feedback, scanning that QR code, I'll be very grateful. Right, happy to take more questions if there is any.
Abhijit, just to say the document says it's not published when I've gone on to scanning that QR code. I don't know whether that's my phone, my tech issues, or what it is.
All right, no worries. I'll put the QR code on the chat box as well then. Right, that would be the end of the session. If you guys okay, no questions then. I hope your time was worthwhile. I made that worthwhile. I've taken long time here, so I beg your pardon for that. It's just that I get very excited about these things. Sorry for taking a lot of time. I'll try to stick to my designated 1 hour then in the next session.
Yeah,
And have a good evening, guys.
Worth every minute, Abhijit. I've put the QR code into the WhatsApp group and I'll add you as well, Abhijit. Great session. What I was going to suggest is what we'll do is we'll do peer review with the next session because we are coming to the close. And what I would say is this video, I'm hoping to publish it tonight because I clearly have a lot of requests for people who want to watch it again. So thank you so much, Abhijit. God bless you. And I'm really grateful. Thank you so much.
Thank you, Alok. Thank you so much. Bye now.